Thank you very much for this introduction, Dr. Twahir. Thank you, Dr. Bara, for inviting me, and thank you for the whole organizing community and for everyone who's here listening to us just before the weekend. So, Bismillah ar-Rahman ar-Rahim, Alhamdulillah, wassalatu wassalamu ala Rasulillah. I just need to double check that you all can hear me well and see my screen. Is this okay? Is everything okay? Basically, we all know what this is for. This is a spoon that we use for eating. But I have seen so many people who get stuck when they're wearing their shoes and using it as a shoehorn. Trust me, I've also seen people using a shoehorn to eat their food. And this is what you do when you don't have enough um, equipment, when you don't have the facilities. But if you have everything, you should put things at the right place. A shoehorn for shoes and a spoon for eating. Now, chefs and housewives and people who are interested in cooking know all those utensils. Personally, for me, if I go into the kitchen, I can use any one of those for everything. I'll cut, steer, big things and grate with it. I don't really mind. But having more and more utensils with more and more facilities is not because one of them is better than the other, but because each one has its use, each one has its function, each one can do a particular function better than the other. In transplantation, we have lots of pharmacological tools. So until maybe a decade or two ago, those were what we have, or what we had. We had ATG, basiliximab, tacrolimus, cyclosporin, steroids, mycophenolate, azathioprine. So why do we need more? And we need more just for the reasons that I explained, because each one of those can be used with better utility, with better functionality in a particular situation. So it's more of personalizing medicine and making and getting the best out of what we have. And in order to be able to achieve our targets, which we haven't really achieved very well so far. So in transplantation, we know the outcomes are much better than in dialysis in most patients, but still we're losing lots of grafts and we want to improve that. What we're trying to do is we hope for our transplant recipients to be as good and healthy as somebody who was never diseased or had any problem with his kidneys before. And the main problem that we face is that people lose their kidneys because they die with a functioning kidney. So we do lose some kidneys because of rejection, of course. We do lose some transplanted kidneys because of recurrent disease and so on, surgical, whatever, but mainly because most patients will lose their kidneys while they're functioning because they died. I know everybody dies, but in transplantation, people die more frequently because of cardiovascular disease, neoplasia, and infections. And this is serious. Because those things are inflicted, or the risk, let's say, is duplicated, multiplied, and intensified because of the immunosuppression that we're using, especially when it comes to neoplasia and infections. So we're using now drugs that can save the kidneys, reduce the events, the rejection events, but that will cause more neoplasia and infections. We know that. And this is the theory. You give immunosuppression, you get viral infections. Viral infections are mainly the main provocative factor that, or the initiating factor that starts malignancies, like the human papillomavirus, like the herb simplex virus 8, and so on. And even those immunosuppressive drugs like calcineurin inhibitors, for example, could be nephrotoxic, and they could be one of the factors that do damage the kidneys for us. And of course, morbid mortality and death of the patients because of this malignancies, the side effects of the drugs, the nephrotoxicity, viral infections. So we need a solution or a new tool or a new drug that doesn't really cause those side effects. And the first thing we tried to do was to reduce the level of the calcineurin inhibitors with the tools that we have, which was the mycophenolate. So it was mycophenolate, low-dose steroids, and reduced dose calcineurin, something like 20 years ago. And it was tried repeatedly, and the outcomes were always worse. Whether you withdraw the calcineurin inhibitors or you reduce the dose of the calcineurin inhibitors, it became very evident that we cannot do that, at least not in the presence of mycophenolate. Mycophenolate is a good drug, but it will not assist you, it will not be helpful when you want to withdraw or reduce the dose of the calcineurin inhibitors. And the wishful thinking bucket was that we need a drug that can improve tolerance, have reasonable rejection, anti-rejection efficacy, maybe have an anti-malignancy or at least not a pro-malignancy effect, can inhibit viral replication while we're using those immunosuppressive drugs, maybe cardiovascular benefits, few side effects. This is just the wishful thinking bucket. And this is what mTORs promised us when they were first introduced. They said, the drug said, I'm going to be there to prevent rejections. I'm going to help you reduce the dose of the calcineurin inhibitors. I'm going to have no anti-malignant, I'm not going to cause malignancies, infections, and that was the promise. So what I'm trying to go through over the next few minutes is to see if this class of drugs has actually achieved those promises or not. I know some of you might have heard me talk about it maybe 1 or 2 years ago in Mombasa, but some things have changed. There's some update because of the main trial, which is the Transform study now, has updates that I need to go through with you. Initially, when the mTOR inhibitors came out, was the promise of cardiovascular protection. It was shown that less left ventricular hypertrophy and less increase in intima thickness of the blood vessels was noted in animals and in heart transplant patients. So that was the start of the promise. Antiviral effect, it was shown that when used instead of mycophenolate with cyclosporin, you get consistently less cytomegalovirus infections and definitely consistently less BK virus infection when you use it with reduced dose cyclosporin. I'm talking about everolimus, of course. The anti-neoplastic effect, especially when it comes to skin cancers and total neoplasia, there was some promises from some studies and meta-analysis that probably the risk of infections is less. And of course, then we got the initial studies. They were small, open label, that there was even comparable or maybe even less rejections when you use everolimus instead of the mycophenolate, because now we all know that you cannot use everolimus instead of the calcineurin inhibitor, of course, except in a few circumstances when you have to, but otherwise it's not a very good idea, because without calcineurin inhibitors, we usually use our grafts. You cannot really get rid of calcineurins unless you're going to use belatacept. Otherwise, till this moment, as we speak, you have to have a calcineurin. So the idea was maybe using small doses of those toxic calcineurins with everolimus, and it was shown that over 24 months, in this study from 2013 from Tedesco Silva, that it could have as effective as even with tacrolimus. When used with tacrolimus, we could still have small or few rejections comparable to the amount to the number of rejections that you will get when you are using mycophenolate with standard doses of tacrolimus. The promise of graft tolerance has always been just an academic physiological pathway sort of thing. This has never been proven for any drug so far. So we'll just skip that. That has not, of course, been accomplished by any drug that we have so far. But generally, to clarify those points and to validate them, we needed a clinical trial. And one of the biggest trials that we have, in fact, it's the biggest trial ever in transplantation, is the Transform trial. It's a very interesting study that wanted to test using everolimus with a low-dose calcineurin inhibitor versus mycophenolate with the standard dose of calcineurin inhibitor, which is what we mostly do, and it's the standard. The primary objective was the treated biopsy-proven acute rejections or reduction in GFR less than 50, with secondary endpoints of treatment failure, including graft loss, death, treated biopsy-proven acute, rejections, and secondary objective, as you can see, relating to the eGFR, renal function, urine protein creatinine ratio, and so on. And there were some, of course, safety endpoints and some small sub-studies for the DSAs and chronic allograft nephropathy, etc. Basically, this was the design of the study. We had two main arms. There were a total of 4 arms, as you will see in a minute, but there were 2 main arms. One arm were calcineurin plus mycophenolate. The other arm was calcineurin plus everolimus. And in the standard calcineurin with mycophenolate dose, there was cyclosporin versus tacrolimus, and also in the low dose calcineurin with everolimus, there was either they were testing cyclosporin against tacrolimus again. Basically, the patients were adults. They were very standard criteria patients, no patients with high PRAs, no DSAs, no history of malignancies, and generally healthy standard criteria recipients. And both groups were quite balanced, and there was always induction. So those patients, all of them got induction, either basiliximab or ATG. So this is very important when you're using de novo everolimus. We have very little evidence on using it without induction. So you have to have an induction if you're going to follow the evidence that we have. And in the standard dose, with mycophenolate, there were the levels we used tacrolimus at the levels that we normally use, which is 8 to 12 in the first 2 months, then 6 to 10, going down to 5 to 8 after 6 months. Cyclosporin, same thing. The doses that we're the C0s that we're used to, if anybody is still using cyclosporin. But in the low dose group, in the minimization group who used everolimus, they started the tacrolimus at a level of 4 to 7, going down by 3 months, 2 to 5, and then 2 to 4 at 6 to 24 months. So remember that figure, 2 to 4 nanograms per milliliter instead of 5 to 8 or 6 to 8 that we use in standard patients. And of course, with cyclosporin, they use much lower levels than the levels that we generally rely on in standard protocols. Those are the primary efficacy endpoints. The rejection and eGFR endpoint, which is the primary composite endpoint, was more or less comparable. And in the secondary efficacy endpoints, which is composite failure, biopsy-proven rejections, graft loss, more or less the same, numerically higher in the everolimus calcineurin inhibitors than the mycophenolate group, and that was at 12 months. So it was slightly higher in those who were receiving everolimus, but not statistically significant. eGFR was more or less the same, and the severity of rejections was generally in most study recipients was quite low-grade rejections. So there were no serious rejections, really. When it comes to the side effects, which is very important, as you've seen in the cases discussed by Drs. Twahir and Dr. Barra, that side effects are sometimes a problem with mycophenolates. Actually, side effects are a problem with all drugs. So the good thing is that in the everolimus group, but of course, more edema, proteinuria, hyper, not very significant at 12 months, but more. Viral infections, which is one of the main issues that make us want to use everolimus, is that we know that using everolimus with a small dose calcineurin inhibitor is going to result in less infections. That was very clear repeatedly. It's very clear, very obvious, very always very significant. Less BK virus infection, less loss of the kidneys for BK virus infection, less CMV positivity and less CMV syndrome, CMV disease. Call it what you will, there's always much less CMV. This is why this group of drugs really have an edge, especially in the infection area, even without prophylaxis, and that's very important. So now you can give your patient low-dose CNI with everolimus and know that you're going even to get less CMV infections, even if you're not using prophylaxis. Prophylaxis can be expensive, it could have side effects, and so on. And as expected, again, at 12 months, there was less BK virus infections. Whatever way you however you measure it, serologically, in the blood, in the urine, histologically, organ damage, less BK virus infection. It's very clear. There's nothing to suspect here. The problem is, as somebody was asking just before I started, the problem with wound healing. At 12 months, the study data was not really fully released, and this is what they showed us. They showed us that the absolute numbers, the total numbers in whether in this or that group, there were no real serious problems. Little wound dehiscence, maybe some lymphoceles, but the main important thing, which is wound dehiscence, there was not really a big difference. There was a sub-study on DSAs to see which group will form more DSAs, and they were comparable again, more or less the same, maybe even less DSAs, de novo DSAs in the everolimus group, which is very reassuring, really, which is very interesting. But then now I need to talk to you about the 24 months data that have come up and published almost a year ago now. So these are the 24-month data from the Transform study, plus more safety data published in more details and more data coming from the authorship of this study. And let me just start by saying that there's nothing perfect in life. So we're not going to call things good and bad. We're not going to call drugs black and white. We're just going to try and understand how to use each utensil in the right place. Because obviously, everolimus did show some reassuring data again at the 24 months analysis. There was less diarrhea and less discontinuation of the drug because of diarrhea, unlike mycophenolate, less leukopenia, less de novo DSAs. It was actually comparable to mycophenolate in the whole study analysis, but it was even better when you compared the patients who were compliant and actually received the drug throughout the study. Everolimus with small dose calcineurin inhibitors formed less DSAs than those with mycophenolate, which is very reassuring, I think. And of course, less BK virus and less CMV, saving the prophylaxis costs, keeping in mind that valganciclovir is an expensive drug, and it's a drug with side effects that can cause leukopenia, which may be accentuated by the drugs that we already use. There are some cautionary notes that we have to keep in mind that in that study, those patients were not high-risk patients. So we're not talking about patients who have had 10 units of blood and delivered 20 children, as people do in Egypt and Kenya. They were just standard risk patients who don't have high PRAs. There were very few Black people enrolled in this study, so I don't really know its applicability to the population that we're dealing with. And even the Black participants were generally of West African origin, so I don't really know the applicability from a racial point of view, how it would really fit in. We have to bear in mind always when we're using those drugs that they can cause infertility in males by causing azoospermia, which is almost always reversible. So if a male is using the drug and wishes to conceive, you know they have to stop the drug for some time in order to regain their sperm production. Females should stop the drug at least 2 months before conception if they're receiving it, which is quite similar to females cannot conceive with mycophenolate either. The risk reduction of neoplasia was not very robust, but let me remind you that these data are only 24-month data. So you cannot really say that it was not protective against malignancies, because those are things that you see after 5 or 6 or 10 years of transplantation. The risk of wound dehiscence, actually, dehiscence was more in the everolimus group, and it was more especially in the obese patients. Now, some people would give small doses of everolimus at the beginning of transplantation, the early days, to allow for wound healing, and this is something you should not do because you could have lots of rejections doing that. If you're worried about the patient having a wound dehiscence because of obesity or diabetes, then probably you should keep those patients from mycophenolate And if you want to switch them to everolimus, you should do that after the wound healing, but do not use a reduced dose everolimus. And let me go back to that slide that I showed you, that as I told you, we were shown initially in the initial data release after 12 months of the transform study. They showed us that there was no real big difference in the absolute numbers, but it was statistically very significant, much more statistically significant, more wound dehiscence and lymphocytes. Nothing really serious, but it was there. So, because there was a debate about that, does everolimus really affect wound dehiscence or not? And obviously it does. Numerically, or absolute figures may not be very high, but definitely more than mycophenolate. Bear this in mind. Another cautionary note we need to say is, as I told you, you should use induction when using everolimus. You cannot say I'm going to do it without induction, because sometimes we achieve the levels very slowly. The everolimus rises, the levels rise very slowly. The dosing, if you're using tacrolimus, you use double the initial dose of when you're using cyclosporin. You have to monitor the level frequently and keep it around 3 to 8. You cannot use everolimus really without measuring the levels. This is important. We do not have facilities to measure the levels. It's going to be very tricky and tacky trying to give the drug. Another very important issue that we have to keep in mind is in the transform study. Let me go back. I reminded you to remind you that the planned level to be achieved after 6 months was 2 to 4 tacrolimus. That was not achieved. That was not achieved. Actually, the average level or the mean was around 3 to 5 nanograms per milliliter. So in standard patients, it was around 5 to 8, and in the low dose with everolimus, it was not 2 to 4, it was 3 to 5. That's very important to keep in mind. The study was designed to achieve 3 to 5, but the results that I'm showing you are not those of where the study was designed to achieve 2 to 4, but the results I'm showing you are actually what was achieved in the study was 3 to 5. So we don't really have this robust data on going as low as 2, unless we have to because of a viral infection or so on. But in a standard patient, you should keep your tacrolimus around 3 to 5 and your everolimus around 3 to 8. And unfortunately, even the endpoints that were very close to each other. So the primary endpoint of rejection and GFR reduction were more or less the same in both arms, but at 12 months, but at 24 months, it started to diverge. Still not very significant, nothing very significant yet, but more in favor of the standard calcineurin inhibitors and mycophenolate, bearing in mind that a big portion of the, let's say, bad, if we should call it bad data coming from the low dose calcineurin was because of the cyclosporin. So cyclosporin kind of spoiled a little bit the results of everolimus. And that takes us to a very important point. If you're going to use a low dose calcineurin with everolimus, even though there is some good data on the use of cyclosporin, but obviously this study tells us that tacrolimus is probably the drug you should be using if you want to go down with the level of the calcineurin. And of course, there was more proteinuria, definitely, not in so many patients, and not very severe proteinuria in most patients, but definitely double the number of patients who will get, you get double the number of patients with proteinuria with everolimus than you would with mycophenolate, and this is probably related to the level of the drug. Higher level of the drug, more proteinuria. Of course, more edema, but the problem is sometimes people are a little bit overreacting when they see edema with everolimus. Overreacting, and by overreacting I mean every time they see edema they just blame it on the everolimus, when in so many circumstances it could be blamed on a calcium channel blocker or weight gain or excessive salt intake. So you have to exclude those first. And pneumonitis is a really serious problem, and you could get lots of that with patients on everolimus. The absolute number is not very big. It's just 1%. So we don't see it frequently. It's dose related. So if you bring the dose down in most patients, you will not see pneumonitis. But it is, of course, much more frequent than what you see with mycophenolate. And we've seen some patients develop pneumonitis, and I can tell you it's not that difficult to deal with. Again, you have to exclude the infections. So not every time a patient on everolimus coughs or has some sputum or whatever, or breathlessness, that is almost always not everolimus pneumonitis. That's almost always infection, just like any other patient. But you still, after excluding everything, if you find no other cause except the everolimus, you have to bring the doses down, bring the levels down. If there's no improvement, or if it is severe, then you have to stop the drug. And we have not had to do this ever, really. So, and of course, there were some more DVTs and thrombotic events with everolimus. So what is the verdict on everolimus? The cardiovascular protection was never really proved in hard, solid data, so we're crossing that one out. Antiviral effect was definitely achieved. Excellent. Anti-neoplastic effect, well, maybe, probably, possibly, it should be. I really, even though we don't have strong data on its anti-neoplastic effect, I'm quite sure it will eventually be very positive, because the drug is used as a chemotherapeutic drug in some tumors, so it's an anti-tumor drug anyway. Graft tolerance, I don't think we can say anything about this. I just crossed that one out. Successful CNI minimization, yes, just with a few reservations, as we said before. So this brings us to the final question. Which is the best anti-rejection drug to use in kidney transplantation? I don't think this is a very wise question. I don't like this kind of questions, because it's just the same as saying, which is the best anti-diabetic drug? Is it insulin, sulfonylureas, metformin, DPP-4 inhibitors? Well, anyone who has treated diabetes knows that we cannot discard any of those drugs. Insulin is the perfect drug. It's the only drug for patients with type 1 diabetes. It's a drug that we use in type 2 diabetes under stressful conditions or when the sugar is not controlled. Sulfonylureas have lots of side effects, but they're very effective and they're very cheap. DPP-4 inhibitors are cardioprotective. SGLT2 inhibitors are cardioprotective. They're nephroprotective, but they're not very strong anti-diabetic drugs. They will not bring the sugar down. DPP-4 inhibitors, less hypoglycemia. See where I'm getting at. What I'm trying to say is that each drug, each utensil has its place to be used. I'm sure if we're stuck in a kitchen with any one of those things, we'll be able again to grate, cut, eat. We'll do everything with it. But if you have all the tools, you'll know how and when to use them perfectly for the perfect patient in the perfect situation. Just like those two professionals don't really get mixed up by those utensils. They know how and where and why to use them. They've got hundreds of types of knives for cutting different kinds of foods. I don't know what they do with them, but they do. So a professional should be able to use all the utensils. It's not black and white. And as we have seen in the previous two cases by Dr. Twahir and Dr. Bala, that there were certain situations where you really had to bring out the everolimus. So I'll tell you what we do at our hospital, at Misr International Hospital in Cairo. When we use mTOR inhibitors, we use them de novo from day -3 to achieve a level, and we combine them with tacrolimus. We do not use calcium, we do not use cyclosporin, because the results, as I showed you with cyclosporin, are not very good. Sometimes we do conversions, and we've done so many conversions for patients with viral infections like BK virus infection, malignancies like Kaposi sarcoma. It was very successful. And with diarrhea, like the patient we saw with Dr. Bella. So sometimes patients have diarrhea that is just so resistant, and you just have to take the mycophenolate out and throw in maybe azathioprine, or even better, everolimus. The levels we use are 3 to 8. We keep them at around 3 in the earlier 3 months for wound healing, and then we go up to 8 later on, but never go below 3. So if you want to avoid the wound healing problems, keep the patient at the lower side, but not below the reference ranges that you should stay at. They're the first choice in patients with polycystic kidney disease, because we know everolimus can prevent the increase in cyst size, which can be problematic in patients after transplantation. if they have not had a nephrectomy. Patients with a history of healed or cured malignancy coming to transplantation, we usually use the drug to avoid a new or a recurrence of a malignancy. Patients who are prone to infections and not prone to rejections, like older people, people who are malnourished and had so many infections while on dialysis, those people are usually the ones whom you should think of when you're using everolimus. And those who had kidney loss, a previous transplant loss to BK virus infection. We do not use it in patients with morbid obesity, severe dyslipidemia, chronic pulmonary disease, because those with chronic pulmonary disease will always come with chest symptoms. You wouldn't know if those chest symptoms are because of the disease in the chest or because of the everolimus pneumonitis. And the same about patients with FSGS, because you wouldn't know if this proteinuria is a recurrence or an everolimus. It will just confuse you. So we do not use it in patients who had massive proteinuria before transplantation. If there are technical issues related to the transplant, like in the vascular anastomosis or in the skin sutures or whatever, we don't use them because of the wound dehiscence that we talked about. And in high immunological risk patients with high PRAs, multiple pregnancies, excessive blood transfusions. So we don't use them in those people. So this is where we use the tool called mTOR inhibitor, basically everolimus. We don't use it for all patients. We're not saying it's the perfect drug. There are no perfect drugs. Each drug that we use has side effects and problems, and a clever physician, a clever transplant physician, is the one who does his best trying to use the proper knife to cut the proper kind of meat, just like Gordon Ramsay would in his kitchen. So thank you very much.
Thank you very much, Professor Nasrallah, for that very illuminating talk on the use of mTOR inhibitors in transplantation. As we're waiting for questions, I just want to you to clarify what should be the sum of your drug levels if you are on tacrolimus and you're on everolimus, and does it change with time, or should you aim for a certain sum throughout your period of transplantation?
Yeah, so this is a very interesting question, because it makes life easier for doctors when controlling the drug levels. So yeah, we always say, as a rule of thumb, generally, that you should have both levels. When you add tacrolimus level plus everolimus level, it should be 8 to 12. Okay. In the first 3 months post-transplant, what we do is we keep the everolimus near 3 and the tacrolimus high, because this is when you need less everolimus to allow for wound healing, and you need more tacrolimus to prevent rejection. After 3 to 6 months, we raise the everolimus to around 5-7, and then we bring the tacrolimus down to around, let's say, 4 or something. So it's still going to be 8 to 12, but always 8 to 12. But in the early phase, everolimus is around 3, and tacrolimus around, say, 7 or 8. And then after 6 months, maybe 5 and 5, 5 and 4, you know, that range. We bring the tacrolimus down and the everolimus up after 6 months, 3 to 6 months.
Okay, good. That's very clear. The other question I have is very practical. When you're titrating your dose, your drugs, either tacrolimus or everolimus, you're faced with a time when the drug dose is not even. For example, if I take an example of tacrolimus, say you'll have a patient with a dose of 2 in the morning and 1.5 milligrams in the evening. And then when you're monitoring your TAC levels the next morning, does it matter whether it's 2, 1.5 or 1.5/2?
So is your question if the patient has uneven doses, which one should be in the morning and which should be at night? Is this the question?
Yeah.
Okay. So there are two. There's no right answer to this question, but there are 2 ways of doing it. We know that drug metabolism is higher at night while you're sleeping. So what many people would do is they will give the higher dose. If the doses are not equal, if they're not even, they'll give the higher dose at night because there's more drug metabolism when you're sleeping than in the morning. But what I do is a little bit different, which is also acceptable. We always give the smaller dose at night because we measure the level in the morning. We always in Egypt, we level the measures in the morning. And we want to see the levels after the small dose to make sure that the patient is not underdosed. So both ways are correct. Each one has its rationale. You can give the smaller dose at night because that helps you monitor the morning level, or you could give the higher dose at night because you don't want the higher metabolism at night to mess the levels. Both are correct. Both ways are okay.
Okay, thank you very much. Are there any other questions, Tasneem?
Yes, Dr. Twahir, there are so many questions. Everolimus is a topic that everyone has a question. So one of the questions they had, Ben Lomatio is asking, should we do more steps like colonoscopy, C. difficile TB before stopping MMF? I think that was to you. And what is the effect of everolimus on long-term graft survival? That is to you, Dr. Twahir.
I think it's been answered quite well by Professor Nasrallah's presentation. There's good survival with everolimus, as good as compared with with the study Professor Nasrallah presented, Transform, where you compared low-dose TAC with MMF and everolimus with TAC. They had equally good outcomes, if not better, and less viral infections with the everolimus. So I think it's a good option to use. And what was the other question?
What is the effect of everolimus on long-term graft survival?
Yeah, I said it's a good outcomes on long term, and as good as using MMF, if not better.
Another question to maybe Prof. Nasrallah is, would TAC Evo between combination of TAC and everolimus versus cyclosporin and everolimus, which one is more promising to offer less rejection?
Definitely tacrolimus with everolimus. Yeah, definitely. So you see, the problem with the everolimus studies is we don't have very long-term data. But reading through the data that we have so far and the results that we have so far, it's probably better to use tacrolimus with everolimus to avoid rejections and reduction in GFR, which is more common when you use cyclosporin.
Dr. Soki is also asking, what is there any data on HIV patients considering the antiviral effect of everolimus?
I am not sure. I don't really know. I'm sorry. I'll pass this one. I don't know if Dr. Tahir knows anything about it.
No, whether there's any role of everolimus in COVID.
No,
Yeah.
in HIV patients.
And no, I have no idea. I don't think so. There's no data on everolimus as an antiretroviral disease treatment. The question which I thought would be asked is, in the era of COVID, and you want to optimize your patient's immunosuppression without compromising their outcomes, would it be a good idea to convert them to everolimus as you are dropping the MMF? That is a good question. I don't know the answer. Maybe Professor Nasrallah, you can enlighten us on, in the era of COVID, what's the role of everolimus to replace MMF?
Yeah, so that was a very pressing question in the early days of COVID. But unfortunately, everolimus was not very successful in this area for two reasons. First reason is everolimus, as we see, as we've shown, cause pneumonitis. So if you give a patient everolimus and they pneumonitis with chest infections and COVID, so it's going to be really very perplexing. It's just going to confuse you. The second thing is that there are some reports of patients who were actually receiving everolimus who got COVID pneumonia So no, the answer is just keep your patients on the standard drugs that they are receiving now. If you're doing new transplants, just evaluate your patients and give them the drugs that they need based on their immunological risk and everything else, taking the COVID out of your um, um, of all your calculations and estimations, especially that we know that there's some in vitro data that mycophenolate might actually have some anti-coronavirus effect. And we know that patients, transplanted patients, do better than the general population in this pandemic. So no, I will not change or modify any therapy because of COVID, to prevent COVID. But regarding HIV, it's interesting. I think we need to look into that. What I can tell you for sure is that all patients with HIV are always excluded from clinical trials. So we can look at observational data if we have any, subclinical data.
Prof. Nasrallah, two more questions for you. So Dr. Peter Maritim is asking, what is the proteinuric effect of everolimus? What is the mechanism? And Dr. Juliet Akoth is asking, how do you adjust the dose of everolimus in patients taking anti-TB medication in a potential interaction with rifampicin?
So the answer to the first question is proteinuria with everolimus is because of podocyte injury. So it's let's view it like, I mean, just imagine that it's something close to what you see with minimal change disease or focal segmental glomerulosclerosis. It could be reversible when you reduce the dose of the drug or when you eliminate the drug, but unfortunately, sometimes it's not fully reversible. The good thing is usually the proteinuria is not very severe, and usually you don't even see it, so it doesn't happen. It's comparable to MMS, but in some instances, yes, it can cause severe proteinuria, much more than what you will see with mycophenolate, and the mechanism is a podocyte injury, a form of podocytopathy, something like focal segmental glomerulus. With anti-tuberculous medications, you do the same adjustments that you do with calcineurin inhibitors. So you know that some of the drugs that we use are enzyme inducers, so you have to be careful that you have to raise the dose of the drug or reduce the dose of you have to monitor the patients very frequently. It's just the same as you do with tacrolimus and cyclosporin. All the drugs that affect, most of the drugs that affect cyclosporin and tacrolimus will affect everolimus in the same way. So at our center, for example, we use verapamil in order to, as an enzyme inhibitor, to raise the doses of tacrolimus and everolimus. Sometimes in some patients, we also, very few patients, we have to use antifungals to raise the level of the Prograf and the Certican. So it's just what you do with anti-tuberculous drugs is when adjusting the everolimus is just the same that you do with the tacrolimus. You bring the dose down by 25%, and you monitor the levels. If you're using an enzyme inhibitor, if you're using an enzyme inducer, then you bring the dose up by 25%, and you must do frequent monitoring, because this is something that cannot really be predicted or anticipated.
Thank you, Prof. Nasrallah. I think all the questions have been answered in one way or the other.
Yeah.
Dr. Twahir?
That is very good. And I think we need to move to the next session in the interest of time. Thank you very much, Professor Nasrallah.